السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
How are you?
الحمد لله.
طيب, can we start now?
We're 106 right now. I think we can start.
Okay. Can you see my screen, everyone?
Yeah.
Okay, excellent. طيب, بسم الله الرحمن الرحيم. Let's start, and يعني the introductory slides probably I think يعني we can يعني repeat them if we need. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. أنا my name is Dr.Manal Alim, and I will be inshallah starting today one lecture, and I will continue that before the end of the week inshallah. And this lecture is about drugs for abuse. Okay. Well, the drugs for abuse, they have more than one classification that you might see. And but for the sake of delivering our lectures, we're going to divide them into two sections: the CNS stimulants that we are starting today, inshallah, and the CNS depressant that will be the second half of the lecture. Okay. I would like to start my lecture with this slide. This, if you can see it, it looks. Can you see this metal container? It looks legal in front of you, and this is actually from the photo of the man or the gentleman who's actually putting something in his nose. This is actually very old, and this method of delivery of tobacco leaves, and this is actually called smokeless tobacco, has been there for more than 300 years ago. And this is for individuals who are addicted to nicotine. So this is a tobacco product that has been there for more than 300 years ago. And all what that individual needs to do is to take a pinch, a small pinch, and he can sniff it or inhale it or chew it, or simply just put that between the gum and the cheek. And it's going to be very quickly absorbed, because I guess you know that nicotine is very highly lipid soluble. You have taken that in your autonomic nervous system in first semester, so you know how lipid soluble it is and will be absorbed from any mucus surface. Is that something that can we say that this has disappeared? No, actually there are certain countries still using smokeless tobacco, like Bulgaria, Brazil, India, China, and even developed countries like the Netherlands, USA, Portugal, Iceland, I think even Germany. There are actually you can find smokeless tobacco. So it looks a little bit strange, but I just want you to know that this is actually one of the method of administration of the nicotine as in terms of instead of the cigarette smoking. Speaking about the drug use and drug abuse, okay, when we as physicians, when we prescribe a certain drug for a certain patient to treat or to prevent, or sometimes even to diagnose a certain condition, then this is definitely a drug use. However, if a certain drug is being used not for a medical condition or not even for diagnostic purpose, it's just being used because it affects the physical or the mental function of a certain individual, then that individual, we can say that he is actually under the influence of drug abuse, because he's not supposed to be taking that medicine for altering the physical and the mental function. And why are drugs being abused? What is the reason that would make somebody abuse certain medications? Either that a drug produces a strong feeling of euphoria. This is actually very, very common reason, because people would like to feel happy and relaxed and not anxious, or sometimes because it alters perception. Yeah, it makes the individual is not aware of what's going on around him or around her, sort of detached completely from the environment. And this is apparently, this is a feeling that somebody would like to have for a certain purpose. And accordingly, the problem is that we're not talking about just the administration for a certain period of time, but because repeated administration, those drugs have certain criteria that would make the individual tempted to repeatedly administer them one after the other. And accordingly, the brain itself will change its chemistry in a way that it cannot function without the presence of that substance. This is the problem now with the drug abuse. And accordingly, there will be actually a long sort of steps in order to reach a stage of addiction. And addiction is the psychological dependence. But when we say dependence, then this is physical dependence. I would like you to know, as physicians, what happens. Say, for example, that we have an individual who has taken one dose from a certain drug, that a drug is addictive. He administered it. He felt something that would make him, that would have a reward feeling or make a certain sensation that he has experienced. And that sensation is getting reinforced by repeatedly taking that drug. What are these sensations? Like euphoria, and as I told you, and sometimes the reward feeling that he would get. Accordingly, he will administer that drug again and again, okay? And until we reach a stage where there is tolerance, dependence, and withdrawal. So these actually come together. Tolerance, I guess you know from your pharmacology, it means tolerance. The individual needs to administer higher doses to get the same effect, okay? Say, for example, if he is abusing diazepam, then he needs one to increase from 1 milligram to 2 to 3 with time, okay, in order to be able to sleep because of the diazepam. And accordingly, he will be physically dependent on it. He cannot sleep without administering the same drug. And if he cannot get access to the medication, what will happen to him? He will have the paradox of the withdrawal symptoms. He will be very anxious, irritable, and having insomnia, and cannot, of course, sleep. Okay. So this is actually the first step in this problem that the patient is facing. Fortunately, successful treatment is likely to happen. If he seeks or his family member seeks medical advice, then the psychiatric physicians who are specialized in that area can help, and he can actually achieve success in his treatment. However, if he does not seek medical advice and he proceeds to a stage where there is psychological dependence, where he have developed a habit and he is losing control and he needs actually to keep administering that drug, no matter what he needs to do, he might attack somebody who might actually steal some money in order to be able to buy it, then this stage is, and yes, we can treat, but successful withdrawal is very unlikely, and the most likely scenario is that they will have relapse even after treatment. All right. So what is the secret of addiction? I'm pretty sure that you know that not every addiction scenario is because of taking certain substance. Why? Because there are people who are addicted to, things that are not sort of chemical substances. There are people who are addicted to stealing, for gambling, for shopping, for plastic surgery, bodybuilding, for example. Okay, so there must be something in the chemistry of the brain that links that certain attitude with the brain and make that individual wanting to keep doing that thing or taking that substance, for example. And this is the most accepted theory, is the dopamine theory. What it means? It means that so far the studies on the human and animal brains, it shows that no matter what is the molecular mechanism that this substance or that addictive drug is producing in the body, eventually it will lead to dopamine release from the dopaminergic neurons in the mesolimbic dopamine system. Okay, and this system actually originates in the ventral tegmental area and projects until the dopamine sort of prefrontal cortex, and accordingly dopamine release is the one that's going to create this reinforcement. What actually makes somebody to relapse is, of course, re-exposure to the addictive substance. If he's facing stress in his environment, if he is getting exposed to the same individuals, same people that he used to take or to inject that certain substance with, right? So unfortunately, that's why a complete rehabilitation program is important for people with addiction. When I put name for drugs, you will see that I put a number next to the group. What is that number? This is the relative risk of addiction. The scale starts from 1 for non-addictive or very mildly addictive substances to 5, which is the top or the highest addictive substances that everybody should be careful from. The classification of the drugs, as I told you, you might see in different textbook, different classification of the drugs of abuse. And this is the one that I just put for you from a paper. The name of the paper is The Mechanistic Classification of Addictive Drugs. And they classify them into three main classes, depending on their molecular mechanism of action. Not like stimulant and depressant, but for the sake of you memorizing and studying the lecture to become very easy for you to know that this is stimulant, this is depressant. But you can see different classifications like this one. Class 1 is the drugs that are working on the G protein coupled receptors. Class 2, they work on the inotropic receptors, and class 3, they work on biogenic amines or the monoamine transmitters in the brain. The group of hallucinogens are always not classified, always kept by themselves, because they, most importantly, we don't know how they produce hallucinations. We know little about them, and because the addiction potential for the hallucinogens is weaker than the rest of the drugs, so it's very unlikely that you will see somebody who keeps coming with addiction problem on hallucinogens. Do you see what I mean? It might be sort of accidental, taking it in for the sake of clubbing or attending party or something, but it's unlikely that you will see somebody who is like, somebody with amphetamine, for example, addiction. So we do not know too much about hallucinogens, and we keep the classification as a separate entity. Let's start with the first and the most important group of drugs, amphetamines. I'm pretty sure that you know that amphetamines is a very dangerous group of medication where addiction actually potential is 5, as you can see it here in front of you. How they were developed, or they are actually synthetic compounds. Initially, a long time ago, there was a search for decongestant, or the search for the sympathomimetic drugs. I guess you know ephedrine and pseudoephedrine, we use them in in cold and flu preparations because they cause vasoconstriction and they cause relieve the sore throat. Apparently, during the search process, of course, ephedrine and pseudoephedrine are safe. Okay, so there's no addiction potential with these medications. But the same class and similar structure ended up with the chemist to produce the amphetamine, which is the first drug. And then once they have been used, and then during 1950s, they have been used for weight loss because they suppress appetite. They are marketed always as performance enhancers. Who would like his performance to be enhanced? You might find, for example, athletes, they might take them before competition. Poor medical student preparing for their exams, they do not want to fall asleep and they want to study all night. Maybe some celebrities, you can find them, even on the internet, that they abuse these medications because they make them eat less and lose weight and become more energetic for whatever performance they are doing, dancing or whatever. So they are actually after they have been discovered that they are having this high abuse potential, then they started to be banned, okay, and very, very much restricted. Their selling and their intake. However, what people who are wanting to make money, what they do is that they change the chemical structure and end up with something different. And that's why you can see here in front of you that we have the methamphetamine. And this is what actually you can see it here. It's called crystal meth. The street names are too many, Saraha. Okay, you don't have to worry about the street names. And it's something nice in this lecture that we're not dealing with a sort of ordinary drugs. So we don't have route of administration. We do not have half-lives to worry about or indications, because these are substances and drugs used for illicit or recreational purposes. So the crystal meth, as you can see it here, this is the way it looks like. And then we have other preparation belonging to the same class called synthetic cathinones. And sometimes they call them bath salts, and sometimes they call them, or we find them over the internet, described as designer drugs, because the chemists and people who are involved in drug design, they design them in a way that either they would like, better pharmacokinetics, they want more intense effect, they wanted longer half-life. I'm pretty sure that people who are trying to involved in drug dealing, they would like actually more and more different preparations in order to make money. So they keep actually inventing, and they keep making new preparations which are slightly different in terms of pharmacokinetics. So if you ask me, for example, and I get always this question, amphetamine versus methamphetamine, it is likely from the few, studies in the literature that methamphetamine is longer acting and more sort of cross blood-brain barrier faster. Okay, so that's why it has got an abuse potential, or it's more popular, I would say, than amphetamine. So they are described as performance enhancers, and they are given either as tablets. Amphetamine is sold as tablets, so they take that, it is taken orally. If you see powder, then it can be dissolved in water and then injected intravenously. This is what the individual who's abusing medication is doing. Sometimes they take that powder and they sprinkle it on tobacco, or they sprinkle it on marijuana, and then they smoke it. Or sometimes when they dissolve the salt and they have this liquid which can be injected, sometimes they dip their cigarettes into it. So that's why they are very creative in terms of how they administer these medications or administer these illicit drugs for themselves. Okay, let's say now amphetamine has gotten access to the human body. What will happen in the brain? Okay, why the individuals are having this performance enhancement? Okay, look at this slide. We have here, this is a presynaptic neuron, and this is the presentation of what amphetamine is doing. And this is cocaine, because cocaine is related, and I'll tell you the difference. What amphetamine is doing is that, Afwan, and I forgot to tell you something about the constituent, because I expect some people to ask me about al-qat. I think you know al-qat. Al-qat is a natural plant that has got cathinones. Do you see this? Cathinones. It has actually caffeine and cathinones, two active or two CNS stimulants in al-qat. And that's why this one is described as the synthetic. So they have taken the same active substance that is available naturally in al-qat, and they made the synthetic cathinones out of that. معلش نسيت أذكر هذه النقطة. Okay, let's go back to the mechanism. Once amphetamine is there, okay, because it's very lipid soluble, can reach the brain. This is actually a neuron, and as you know from your autonomic nervous system, that the neuron is making monoamine transmitters. It's making dopamine, norepinephrine, serotonin, whatever. And once they are made, okay, they are being released with the action potential to the synaptic, cleft. And then they will go to the postsynaptic neuron. Let's imagine that there is another neuron here and do their job. The excess dopamine, normally what will happen to it, it will be reuptaken back and stored into vesicles. Again, the newly synthesized can store into vesicles. Okay, what will happen? This we know. But what will happen with amphetamine is there. Amphetamine actually, the first thing that will do, it will compete with the dopamine transporter. Do you see this red structure? This is actually a protein attached to the cell membrane. It's supposed to be taking dopamine to inside the cell. Any excess dopamine here takes it inside. But unfortunately, when amphetamine is there, amphetamine will compete and it will go inside the cell instead of dopamine. So the first thing that it's going to compete with amphetamine for the dopamine transporter. What will happen next? Then amphetamine will be there in the cytoplasm, isn't it? Once it gets to the cytoplasm, it will go here and inhibit this structure, which is called the vesicular monoamine transporter, VMAT. From the name, I think the name explains itself. This is the vesicle. It is attached to the membrane, and it's supposed to be transporting monoamine neurotransmitter to inside the vesicle to store them. But amphetamine is going to inhibit the function. So any newly synthesized dopamine will stay in the cytoplasm and accumulate. What will happen to it? To get rid of it, the dopamine transporter now will have a reverse function. Instead of taking it inside, it will take it outside because it has too much in the cytoplasm from dopamine, right? So basically, this is what will happen. This is what is described as reverse transport of dopamine transporter. So this is what amphetamine is doing. It's not only this is what amphetamine is doing with dopamine. No, it does that. The same mechanism, it does that with norepinephrine and serotonin. Can you imagine how much of those neurotransmitters will be available for the brain to modify its function. So you have excess, that individual has excess dopamine, norepinephrine, and serotonin. I hope the mechanism is clear. Let's go and have a look at cocaine. Cocaine is related, same clinical picture to amphetamine. However, the mechanism is slightly different. In what way? Cocaine only inhibits the transporter and will not allow the transporter to take dopamine and norepinephrine and serotonin to inside the cell. So it will accumulate here. But we do not see this reverse, transport business that it does by amphetamine. Eventually, in both conditions, you will have higher bioavailability from dopamine, norepinephrine, and serotonin. Okay, what will happen next? This high concentration of norepinephrine in the brain, it's you can describe it as sympathetic stimulation, isn't it? So the individual will feel very much attentive, alert, vigilant, but don't forget your heart rate and blood pressure, it is high, okay? And unfortunately, because in these medications or these substances, we don't have a dose, right? These individuals keep taking, whatever makes them happy. So they're not going to stick with a certain dose, all right? So in case that you find somebody presenting with intoxication or very toxic dose of amphetamines, then unfortunately they will be having tachyarrhythmias, hypertensive crisis, they might present with a stroke, and they might present with myocardial infarction. What is the reason? Because it is overstimulation sympathetic nervous system. You have receptors, okay? You have this hypertensive crisis because of the extreme vasospasm and vasoconstriction. And with the vasoconstriction, can you repeat the mechanism of cocaine? Okay, هرجع للmechanism of cocaine. Okay, mechanism of cocaine only it actually blocks the transporters, whether it is dopamine or أنا ماني عارفة when I move the slides يا جماعة, can you follow with me the slides, or I need to stop the sharing and share again? Yeah, now I am with the cocaine mechanism of action. Are you with me?
Yes.
Okay, excellent. So do you see this transporter here is being blocked by cocaine? So whatever is being synthesized, released by the action potential, it will still be there. It will not be uptaken and stored again. That's the mechanism of action, and does that for every transporter: serotonin, norepinephrine, and dopamine transporter. Okay, let's go back to the slide. So unfortunately, having so much catecholamines on board will lead to vasoconstriction. Don't forget that. So that will lead to rise in the blood pressure, and sometimes imagine ischemic stroke or myocardial infarction because of this severe vasospasm, and sometimes even hemorrhagic stroke. Why? Because this very high blood pressure bursts blood vessels in the small blood vessels in the brain, can precipitate stroke. And for that reason, it's sort of well known that any individual who is young enough and presenting to the emergency room with MI or stroke, you will start to think, why, for God's sake, he's getting stroke or myocardial infarction? He's too young. He doesn't have risk factors. So think about amphetamine or cocaine abuse for this mechanism. Now you understand it. You remember your autonomic nervous system, high catecholamines would cause pupillar dilator muscles to dilate, so they will have wide pupil. That will help you in the diagnosis. Excessive sweating, as well as, of course, they do not fall asleep. What about the accumulation of dopamine? What is it going to produce? Euphoria, feel happy. Don't forget, the dopamine is related to psychosis if it is excess, so psychotic symptoms, and of course it will mediate the addiction for that poor individual. And they might present with abnormal movement because that dopamine smooth out locomotion, so now excess dopamine might disturb the normal movement and locomotion. High serotonin, very happy, not anxious, having hallucinations and psychosis and hyperthermia. So all of that, is brought about by amphetamines. And of course, you know that if there is death that has happened, intoxication, then definitely it's because of either the extreme of the intense cardiac arrhythmias, or because of the stroke that has affected the patient, or because of the hyperthermia and the dehydration, whatever the complications or seizures that can happen with that. Okay, before we go to cocaine, I would like to tell you about phenethylene. Phenethylene is another drug that belongs to the amphetamine group, and the name that is well known for it is Captagon. And I would like to tell you about it because it's very common in the Middle East. The abuse of Captagon is actually very common. So what is Captagon? It's the thiophyllene derivatives of the amphetamine itself. Okay, so it has got like two actives, so amphetamine with thiophyllene. The search for phenethylene, when it was produced or manufactured in 1961, usually, they think maybe because, as I told you, in 1950s, they discovered that they are having high abuse potential. So in 1961, they thought maybe this formulation is going to be better or at least milder than amphetamine and less abuse potential. And they started to use it in attention deficit or narcolepsy and some cases depression. But then they discovered actually that is very, very, again, the abuse potential was 5. Okay. And then it was restricted. So strict prescription status was put in 1981, but then withdrawn in 1986. خلاص. So now anybody who's selling Captagon, that is under drug trafficking. So they are actually trying to make money from that. Why it is again popular? Because once it's taken into the body orally as tablets, it will be metabolized and will release these two important components. So we know that amphetamine is a strong CNS stimulant. Theophyllene is another CNS stimulant, but milder than amphetamine. And don't forget even that the parent drug itself, phenethylene, is very strong stimulant. So like another way of saying 3 in 1. So that's why it's very strong stimulant. And the reason why it is very popular and available everywhere, because two things, Sarah, you need to know, is that the production of Captagon, it does not need any expensive lab facilities. Little instrument that can be bought and brought home, okay? Secretly, it helps to manufacture Captagon tablets or prepare the substance and definitely press it into tablets. And the second reason is that the raw material that somebody might need in order to produce Captagon is available and legal to buy. So it's not something you need substances to bring them from somewhere and smuggle them. No, actually you can, the chemist who would like to design it can get the raw material and can manufacture it at home. That's why it's very common among drug trafficking. Okay, let's go now to cocaine. It is related, if you know, I've explained to you the mechanism of action. What is the source of cocaine? Cocaine comes from leaves from plant called coca plant. The coca plant is grown in South America in the Andes Mountain. And local people, they know it very well. They take the leaves of this plant and they chew them, or they take the leaf and boil them and make a tea, okay? And then they drink this tea, which is an energetic tea and give some kind of stimulatory effect to the CNS. But it's not as, the alkaloids available in the coca leaves, or they call it coca alkaloids, the natural ones, are not actually addictive. It's not like cocaine. But how cocaine is being produced, they take the coca leaves, okay, and then they have high process, they highly process it into cocaine. A lot of chemical reactions that happens in between in order to produce the cocaine, okay? So it is actually introduced to medicine since 1881, or 1880s, to medicine, and was introduced as local anesthetic. على فكرة, can you imagine that, the original formula from Coca-Cola, it was introduced in 1885, and they have actually included cocaine in the original formulations. Okay, and then a few years later, after they discovered the addiction potential, they changed the formulation and they have taken another ingredients from the same plant in order to preserve the flavor of Coca-Cola, or the distinct taste of Coca-Cola. So initially it was cocaine, okay, and then it was changed to another formulations. Okay, why cocaine was used in 1880s in medicine? It was used as local anesthetic because in addition to what I've just explained about monoamine transmitters, it blocks sodium channels. Anything that blocks sodium channels, you have taken your acute your anesthetic lecture, you know that anything that blocks sodium channels, then it will interfere with the sensory neuron activity. So you can perform surgery without the patient knowing. So it was started in eye surgery and then nose, throat. Yeah, it was used actually for some time. But after discovering the abuse potential from systemic absorption, people stopped using it. Okay, and the other thing that would make it popular, because with this intense norepinephrine bioavailability, it causes vasoconstriction. And vasoconstriction is something ideal for any surgery في الواقع, because you do not want the patient to lose too much blood and you cannot see what you are operating on. Okay, so again, cocaine is supplied as powder. The powder usually is the salt. They can dissolve it, inject it intravenously, or snort it into the nasal route. Again, same principle. They can sprinkle it or mix it or whatever, and then can be smoked and very, very quickly absorbed through the lung and goes to cross blood-brain barrier and go and produce this high or the instantaneous rush that they feel. The acute effect for amphetamine is exactly like the cocaine is exactly like amphetamine, because again, it increases the bioavailability of norepinephrine, dopamine, and serotonin. Right? What you can see here in the picture is the crack cocaine. Crack cocaine is the free base, and apparently it needs some steps. So the cocaine powder, it can be changed to the crack cocaine, and this is the form that most of the people would like to smoke better, right? طيب. Again, the same thing. Overdose will lead to intracerebral hemorrhage, ischemic stroke, MI, seizures, and for amphetamine and cocaine, both of them, we do not have an antidote, right? Unfortunately, we do not have an antidote that can help. We only need to do some supportive therapy. What's the supportive therapy that we can do? They are hyperthermic, okay? So we use cooling blanket, ice packs, push IV fluids because of the dehydration. They are having so much excitement and probably seizures. Give them diazepam or benzodiazepines in order to calm them down and sedate them. If they are having high blood pressure, use medication for blood pressure, as simple as nitroglycerin, nitroprusside. Too many options are there. But the only warning that I would like to tell you is that do not use beta blockers alone. Because if you block beta receptors, the catecholamines, they are going to go to alpha adrenergic receptors and cause worsening of the vasoconstriction response. Okay, so okay, I mean the hypertensive crisis becomes worse, severe vasospasm. So if you want and you have only option to reduce their blood pressure to give beta blocker with alpha blockers. Okay, that's important point. Last thing that I would like to tell you about cocaine is the adulteration. Okay, usually drug dealers, in reality, they don't care what they put. They just want to make money and to sell more and more from that, toxic powder. So it's a habit that they do not actually give the pure cocaine. Okay, that's why people, the ones who are abusing it, they like the crack cocaine because it's a free base. But when they buy the cocaine powder, it will be mixed with another powder. This is what the drug dealers are doing. They mix. Yes. Anybody wants to say something? Okay, so let's go back to the adulteration. What is adulteration? They take the powder of cocaine, which is whitish powder. They mix it with another whitish powder to give it more weight and sell more. The unusual actually adulterant or the cutting agent that they use to mix it with is talc powder. I guess you know that talc powder is available in every pharmacy. They can get it and mix it, cocaine with it and sell it, right? But some actually drug dealers, they like levimazole. Levimazole actually probably the criteria or the color or the weight or the consistency looks exactly like cocaine. So levimazole is an antiparasitic agent and some immune modulating agents as well. So it is a medicine by itself. So they take levimazole, mix cocaine with it and sell it. Okay, what will happen now for individuals who are using cocaine or snorting cocaine or abusing cocaine? They might be affected with the side effect of levimazole. and it has got actually dangerous side effects. One of them is agranulocytosis. So white blood cell count gets, very low. They might be getting superimposed infections. Okay. The second, again, side effect that is very dangerous is vasculitis. Vasculitis, whenever it's an immune modulated, once vasculitis happened, there will be small thrombotic lesions inside the blood vessels, and then that will lead to cutaneous necrosis. Can you imagine what happens? See this picture here. This is a case report, and this is the journal, Addiction Science and Clinical Practice. This is a 44 years old lady who is actually abusing cocaine for years. Okay, what do you see? What do you notice about the ears here? Can anybody?
Necrotic.
Yes, they are necrotic. Apparently, and look at the cheeks. This is again, the cheeks here actually, you have this red, it is actually raised from the skin. So when she came, she was actually complaining from fever and this painful rash on the face, cheeks, ears, and other areas of the body. So that's basically the vasculitis that has happened from the bimazole. But of course, she said that she's abusing cocaine. And you see these necrotic changes on the ears, unfortunately, it's because of the levimazole side effect. So this is important for you as physician, because don't think that your diagnosis is incorrect or there's something missing. You need to know that these substances can be mixed with something God only knows what it is. Okay, what do you notice about the nose of this patient? The nose too. Yes, excellent. Somebody said the nose too. Well, the nose is not because of levimazole. The nose here, they describe it as self-amputation. This is because of the cocaine abuse. Why? Because cocaine, you know that it's a vasoconstricting agent, صح? So when they snort cocaine, and this is actually the best route of administration for them, they will cause repeated vasoconstriction locally to the nose cartilage. And accordingly, the cartilage will die off because, and will be atrophic because it does not have enough blood supply because of the cocaine local effect. Okay, so on that reason, a lot of people who are abusing cocaine, they will lose their cartilage in the nose. They might undergo perforation, atrophy. If you go to the paper, you will see other pictures, but I did not want to put the picture that would show her face clearly. But you can see how the nose is destructed and gone. And of course, you can see here, there is some necrotic changes that has happened because of the levimazole. But losing the nose is because of the vasoconstriction because of cocaine. And don't forget, cocaine is local anesthetic. يعني المشكلة إنه مو حاسس. يعني they won't actually feel that this problem is happening, unfortunately. Alhamdulillah. Okay, so we're done from amphetamine and the amphetamines and the cocaine. Let's go now to ecstasy. Ecstasy is between the hallucinogens and the pure CNS stimulant. Why? Because ecstasy, as you can see it, do you see the structure here is written? Yes, everybody is with me here saying vasoconstriction is very important cancer. Do you see the ecstasy is abbreviated as MDMA? Do you see how many, these are collection of ecstasy tablets from all over the world, different shapes, different colors, and attractive colors. Ecstasy, MDMA, that's methylene dioxymethamphetamine. So it is related. The reason why we classify it as CNS stimulant is because it's related to the amphetamine group. But the way that it deals with the biogenic amines, it prefer actually the serotonin transporter. It's not going to affect too much or intensely dopamine and norepinephrine transporter. That's why the picture of ecstasy is more like of having serotonin syndrome with the excitation, of course, euphoria, hallucinations, and hyperthermia, and some psychosis as well. So the picture is more like serotonin rather than the rest of the three neurotransmitters. Okay, and because dopamine is not involved fully or intensely, that's why it's not very highly addictive, although that we do not know exactly the addiction potential for ecstasy, but it is likely that it's much less than the other two classes that we have just covered. Sometimes the individuals, because of the hyperthermia, they feel very much warm and hot. So they drink excessive amount of water. And drinking so much water will lead to water intoxication. And you know the electrolyte, what will happen? Dilutional hyponatremia, and that would give rise to seizures, okay? And yani, if it is very toxic, it might lead to death. But we do not have an antidote again, and usually the treatment is supportive. Yeah, exactly like what we have just said in the amphetamine and cocaine, just supportive therapy. Okay, the word psychedelic, I will explain it in a second. The next slide. Now let's go to the group of hallucinogens. We have two slides about hallucinogens. Hallucinogens, uh, usually, yani, when I used to cover this lecture, I do not sub-classify it. Hallucinogens can be sub-classified into three categories, all right? Um, it was after one medical student asked me, so that's why I need to put that. Because why I do not like to confuse you, because yes, we do have subcategories, and the experience, if you ask an individual who has taken one of them, he will give you different experience in each. However, in toxic circumstances or in situations where there is intoxication, there will be an overlap in the presentations. So I will explain to you right now, and you will find it's a little bit, tricky whether I can distinguish between the three categories or not. Okay, the three categories are the deliriums, or these are described as the true hallucinogens, the dissociatives, and the psychedelic agents. Okay, it depends on what they produce. That's actually the simple way to explain it. The deliriums produces delirium, and you know what is delirium? Is the individual will present with confusion, agitation, confabulations. He might be dysphoric and unable to recognize themselves or engage into a conversation. Delirium is different from psychosis. And if you have studied delirium and psychosis, delirium involves sometimes involuntary activity like tremor. Sometimes it involves even vital signs abnormality like tachycardia and fever, in addition to this profound effect on the cognitive function. Yani orientation, attention, concentration, all of it is gone. Of course, hallucinations will be there in all the three subcategories. Okay, so what are the substances that classified as deliriums? These are not typically drugs. These are natural plants available in nature, and some individuals might actually by mistake or sometimes deliberately use them. And the most well-known and well-known group of a plant in botany is Datura. Datura is a big genus, and it has got like 9 species, and all of the 9 species under the name of Datura, all of them are poisonous. Okay, so they have psychoactive substances that produces delirium state. The other source is Atropa belladonna. As you know, that this is the source of atropine and scopolamine. It has got other, deliriant or substances in its structure that can be or accidentally affecting individual and producing some state of delirium, and of course with hallucinations. When we go to the second group, or second subcategory, which is the dissociatives, we have three famous or well-known drugs that are producing this dissociative effect. The phencyclidine, it's a drug for abuse, it does not have any other indication. Ketamine is an anesthetic. And dextromethorphan, if you know dextromethorphan, one of the actually over-the-counter medication, because it's one of the opioids that is used as cough suppressant. Now, dextromethorphan abuse is very common in teenagers because it's available in pharmacies as cough suppressant. So they take too much and they drink it all together, like 3 or 4, bottles and drink them. It's not, they stick with a certain dose. And with having an overdose from dextromethorphan that they can access from pharmacies, they will have this dissociative effect. What does it mean? It means that the individual will have a distorted perception of sight and sound. طبعا, this is actually the other way of saying that they have hallucinations. But the most important and distinctive feature is that this feeling of detachment, or they feel that they are dissociated. من فين? Dissociated from their environment. They feel that they are detached from their own body. This is the way that they describe this feeling that they have with the dissociative agents. And for that reason, they are classified as separate entity. This is datura, actually. It's a very flowering plant, and the flowers are very toxic. Let's go to the third category of hallucinogens are the psychedelic. Psychedelic, that means from the name, produces psychosis or psychotic symptoms. And the most well-known psychedelic are LSD, which is lysergic acid diethylamide, and we have mescaline, and we have psilocybin. Okay, the LSD is supplied as tablets. It is the most potent. And then mescaline is less potent. Okay, another, again, supplied as oral tablets. But psilocybin is the name of the mushroom. Okay, if you know that, I think in your autonomic nervous system, you have come across the magic mushroom or the toxic mushroom that produces a state of euphoria, hallucinations, and some psychotic symptoms. Okay, so the psilocybin is the name of the mushroom and the name of the active substance, because they can take LSD, as I told you, as tablets, mescaline as tablets, psilocybin as they can eat the mushroom itself. 20 to 30 grams only is enough from that mushroom to produce the recreational dose. And some individuals, they might dry this mushroom and make it as powder for easier transportation, whatever. And 1 to 2 grams from the powder can produce the recreational effect of the psilocybin. So they alter mood, the mood is better, thinking process is distorted, hallucinations are there. So basically it's a psychosis. And the difference between psychosis and delirium, psychosis, they do not have extreme sort of disturbance to the cognitive function. They can actually engage in conversation, they can be coherent up to a certain point, okay, and they do not have problems in their vital signs, okay, and no tremor or no involuntary sort of activity. So there is a small difference, but to be honest with you, if they are taking toxic doses or high doses from these substances, then you might not be able to differentiate one from the other. But this is for the sake of classification. The psychedelic, what we know so far is that they work as agonists on serotonin 2A receptor. Again, no antidote, just supportive therapy because it is self-limiting. And luckily, do you see the abuse potential is only 1. So it's not going to be any frightening in case of addiction potential for the future. All right, let's go to nicotine, the last slide. Do you see the abuse potential of nicotine is 4? Okay, addiction to nicotine, the problem with addiction to nicotine is because actually nicotine is one of the most widely spread, substance of abuse all over the world. And probably, cigarette smoking actually causes premature death and cancer. And in certain countries, unfortunately, you can find more than 50% of the individuals are being, smoking, okay? So smoking, chewing, or smokeless tobacco, as I explained to you. Nicotine, you know that it's actually works on nicotinic acetylcholine receptors in the brain. Once it's smoked, it's very lipid soluble, goes to the capillaries in the lung, pulmonary venous circulation, to the heart, and after in the heart, it's going to the brain. And it produces this, acetylcholine, what it does, increases attention and, pleasure, and reduces stress and anxiety. So they feel actually that they can concentrate better and think better. Few question? Okay, let me now for the nicotine, the addiction, the nicotinic acetylcholine receptors are available on dopaminergic neurons, so they increases dopamine release. It even increases the release of other neurotransmitters other than acetylcholine and dopamine, serotonin, endorphins, catecholamines. we don't have time to explain the molecular mechanism, but you need to know that nicotine creates a status of, sympathetic stimulation and over concentration. And if somebody is not smoking, then he will have the completely opposite phenomenon. Now, how can we help somebody with nicotine addiction? We have first-line medications: nicotine replacement therapy, varmecilin, and bupropion. These are the 3 main smoking cessation aids that we have, and they are approved for that reason. Nicotine replacement therapy, you know that the cigarette smoking itself is very harmful and has got many toxic substances that are, that can be responsible for cancer, like hydrogen cyanide, carbon monoxide, ammonia, aromatic hydrocarbons. The individual is not addicted to them. The individual is addicted to nicotine by itself. So we need him to stop the smoking and get exposed to all of these poisonous materials and get only exposed to nicotine that we can cut slightly and gradually over time, by which we can help them to quit smoking. The best thing, nicotine replacement therapy. We have lots of preparations. We have gums, lozenges, spray, inhaler, and the long-acting is the patch, because once they stick the patch on their arm, it can actually supply nicotine with a certain concentration for 24 hours. So we advise certain individuals, they want to stop smoking, use nicotine replacement therapy, use it actually for some time. Use it for 8 or 12 weeks. Use long as well as short. They can stick the patch, and they can take the gum. They can take up to 20 pieces of gum every day. It doesn't matter. Every 1 to 2 hours, they can chew one gum, and they chew it for 30 minutes. This is the time that he needs in order to release the nicotine from the gum and give him an extra dose of nicotine in addition to the patch that he is sticking on his arms and arms or abdomen. And with time, try to, the healthcare professional who's helping him to quit, he's going to reduce the dose gradually with time. Okay. What is barnicillin? It's a nicotine receptor partial agonist. So it blocks the nicotine receptors, will not allow nicotine from cigarette smoking to bind with it, but it will produce partial agonist activity. So it's not like, he will feel that he's totally does not have nicotine on board. No, he will have, a smaller or weaker effect of nicotine. We give barnicillin as oral tablets, and we give the patient, he should start 1 week before the stop date that he's planning to stop smoking, to allow the kinetics or pharmacokinetics to have a steady state concentration in the blood. And then he stops smoking altogether, okay, and continue barnicillin for another 11 weeks, and that will help him in not to relax. Bupropion is atypical antidepressant, and we do not know exactly how it helps, but it is thought that it might enhance the release of certain neurotransmitter, dopamine and norepinephrine, and that actually elevates the mood and help him and support him to quit smoking. Again, 1 week before, 11 weeks after. And this is the plan. If the plan fails, please repeat the same plan for longer duration of action. Can I combine? Yes, you do. Combine nicotine replacement therapy with barnicillin or bupropion, 2 drugs together. Do whatever you can do in order to help that individual to quit smoking. Repeat the plan again, even if it takes 6 months or long, it's worth it at the end of the day. And please provide that individual with enough counseling and smoke-free environment, because you don't want them to relapse, do you see what I mean, and go back to cigarette smoking, because the success rate is poor, I have to say. But of course, it depends on what kind of support that these individuals are having, and what kind of therapy. Did they have somebody who's healthcare professional specialized in that area to help them? At the end of the day, we need to help them as much as we can in order to stop smoking and be more healthy. So that does it for the CNS stimulant. If you have any questions, if I have time for questions. Let me see my chat. Can you repeat the concept of avoiding beta? Okay. In cocaine overdose or amphetamine overdose, you're having high bioavailability of norepinephrine. Norepinephrine, of course, طبعا it's a precursor, ممكن epinephrine again, okay? And these are going to go and bind with alpha adrenergic receptors and beta adrenergic receptors, okay? And they're going to stimulate, cause vasoconstriction with the alpha and tachycardia with the beta. We agree on that. Okay, if you want to reverse their effect or to treat this high blood pressure that they're having, and you want to give beta blockers, yes, they will displace and occupy beta adrenergic receptors, but you have to be prepared that this catecholamine is going to move to the alpha adrenergic receptors, okay? And it's going to display, it's going to, the catecholamines will go to the alpha adrenergic receptor and cause vasoconstriction. Do you see what I mean? So if you want to block both, or use another nitroglycerin, something that works with nitric oxide to vasodilate and reduce the blood pressure, Okay, that's I hope that's clear to you. Doctor, what addicted to delirium? I meant to cause dysphoria. Yeah, yeah. The deliriants, they're not the drugs that somebody's after. Okay, the deliriants are substances that somebody might. I agree with you. If they are producing dysphoria, why would somebody use them? But somebody would use them by accidentally, or sometimes, يعني, في certain countries and during religious, ceremonies, they drink or they take certain substances that God only knows. So I wouldn't say that it's intentional, because yes, they produce dysphoria. I agree with you, but it might happen as accidentally exposure to a certain plant. Number one means no addictive effect. Yes, low addictive potential. That means, is the individuals likely to be addicted to them with repeated administration, or no, they do not become addict to it. So one is weak. Any other questions? I do not know if, well, I know that cocaine, amphetamine, they do not have an antidotes used. Okay, so I don't think, yani, there are no antidotes for them. NRT itself is nicotine replacement therapy. Yes, we have nicotine in the patch, we have nicotine in the gum with different preparations. And I don't have time. There are gum that has got 1 milligram of nicotine, and one gum you can find 2 milligram of nicotine. You have patch that has got 14 milligram of nicotine per patch, one patch that has got 21 milligram of nicotine per patch. So we choose the concentration depending on number of cigarettes that he smokes. If he's a heavy smoker, we go with the highest concentration from the gum and the patch. If he's not, yani, or he has actually quit, or he's halfway through, then we might use the smaller doses. Yes. NRT is basically, we are giving literally nicotine to the patient, but we are giving nicotine without the toxic substances that comes in the cigarette. That's the most important thing. You're welcome. I know it's interesting. على فكرة يعني في other street names. One of your colleagues sent me, just before I forget, there is something called Bromo Dragonfly. This is another psychedelic substance. Dimethyltryptamine, DMT, another psychedelic substance. And يعني street is full of medications. But when you read a certain name that you do not know, just go and try to see what is the structure and under which class it falls, and then you will know how to manage or what the presentations are. Thank you very much.